Assalamu alaikum, everyone. I am Dr. Mohammad Zamil, a first year resident hematologist. Today, I will be presenting on topic that often hides in a plain sight multiple myeloma, a hidden cause of anemia. First, I will briefly explain about multiple myeloma. It is a clonal proliferation of the plasma cells leading to excessive production of the monoclonal proteins and light chain Benjos proteins. Basically, plasma cells are mature B lymphocytes which involve in the synthesis of the polyclonal proteins called immunoglobulins. It is a normal structure of immunoglobulin containing two light chains and two heavy chains binding with disulfide bond. The tip of Y-shaped structure called variable region and it provides antigen binding site, while the lower end called constant region which provides structural stability and involving complement fixation. There are two subunits of light chain called kappa and lambda, while five subunits of heavy chain, including Ig, A, M, E, D, and G. The diagnostic criteria of the multiple myeloma, there should be more than 10 percent of the plasma cell in bone marrow, with one and two of the following myeloma defining events like there should be hypercalcemia, serum calcium level should be more than 11 milligram per deciliter, serum creat level should be more than 2 milligram per deciliter, and hemoglobin should be less than 10 gram per deciliter. Also monolithic lesions on the CT scan. Or we can also diagnose the multiple myeloma through more than 60% of the plasma cells in the bone marrow. Or we can also diagnose the multiple myeloma on the basis of the serum free light chain ratio more than 100%. Slim crab is a mnemonic used for the multiple myeloma in which S stand for 60% of the clonal plasma cells in bone marrow. L stand for light chain ratio should be more than 100%. And M stand for MRI in which more than are two monolytic lesions. Crabs are the basic features of the multiple myeloma in which C stand for calcium and there will be hypercalcemia in multiple myeloma. R stand for renal insufficiency, A stand for anemia, and B stand for lytic bony lesions. Lytic bony lesions and hypercalcemia are interlinked with each other as they are increase in osteolysis of the bone in multiple myeloma through two basic mechanisms. The first one is that there will be increase in the resorption of the bone through activation of the osteoclast cells, which obviously cause lysis of the bone. The second mechanism is that there will be suppression of the bone formation through suppressing of the bone forming cells, which called osteoblastic cells. So due to these two mechanisms, there will be increase in osteolysis of bone, leading to this mineralization of the bone and forming lytic punch out lesions. And because of that lytic punch out lesions, there will be a backache, which is the most common symptoms of the multiple myeloma. There could be a pathological fractures upon minor trauma, and there could be a hypercalcemia as well. And due to hypercalcemia, there could be a stress, confusion, abdominal pain, constipation, bony pain, and the calcium stone formation as well. Failure in multiple myeloma, again, there are 3 to 4 basic mechanisms behind that renal impairment. The first one and the basic mechanism that involved in the renal impairment is the incorporation of the free light chain with the renal tubules. Basically, free light chain excreted normally through the kidneys. So their concentration normally is less than 10 milligram per deciliter. But in case of multiple myeloma, as there is a paraproteinemia and the concentration of the light chain proteins, which basically is the Benjohn's proteins, increases in our body. So their concentration exceeds the limit of the kidney to eliminate them. So that's why their incorporation resulted in the destruction of the renal tubules, which further causing the renal failure. The other mechanism that can cause renal failure is the hypercalcemia itself, as calcium also secreted through the kidneys, and it can also cause the formation of the calcium stone within the kidneys, damaging the renal cells. The third mechanism that can also affect the renal cells in case of multiple myeloma, as the backache is the most common symptoms of the multiple myeloma. So most of the patient tends to use NSAIDs for pain. So these NSAIDs is directly nephrotoxic as well. Apart from crash features, there are other conditions as well that can occur in multiple myeloma like amyloidosis, hyperviscosity syndrome, and polyneuropathies. It is a flow chart describing the pathophysiology of the multisystem involvement of the multiple myeloma, in which there is a clonal proliferation of the abnormal plasma cells leading to the excessive production of the monoclonal proteins, deficiency of the normal polyclonal proteins, and bone marrow infiltration. Uh, Excessive production of the monoclonal proteins can lead to the formation of myelaidosis due to deposition of the insoluble amyloid fibril with the renal tubules. It can also paraproteinemia can also lead to hyperviscosity syndrome. Uh, the outer membrane of the RBCs contain negative charge. So this negative charge is responsible for the electrical compulsions between the cells. So in paraproteinemia, these negative charge are present outer membrane of RBCs gets lost. Due to that, there will be clumping and sticking of the cells, forming a chain of kinds called Rayleigh formation, leading to increase in viscosity of the blood and which called hyperviscosity syndrome. Renal failure due to incorporation of the light chain benzoate protein with the renal tubules. Decrease normal polyclonal proteins will cause immunodeficiency, which further causes the recurrent bacterial infection, most commonly Staph aureus, Strep pneumoniae, and E. coli as well. These recurrent infection can also cause renal failure. Bone marrow infiltration will cause anemia, and bony destruction. And bony destruction can further cause hypercalcemia, neurological symptom cause of compression, fractures like there will be compression of the cranial nerve as well, and bone pains as well. Lab investigation, the first basic investigation is CBC with peripheral examination, and in CBC there will be normochromic normocytic anemia in case of multiple myeloma. And if we examine the peripheral examination, there will we can see a chain of kinds called Rayleigh formation as well due to paraproteinemia because of loss of negative charge. ESR will be raised. Serum protein electrophoresis is a specific test for the to establish the diagnosis of the multiple myeloma. In serum protein electrophoresis, is basically separate the serum proteins on the basis of their electrical charge. There are two major proteins present in our body: albumin and globulins. Globulins further divided into alpha 1 globulin like alpha 1 antitrypsin, alpha 2 globulin like ceruloplasmin, beta globulin like transferrin, and gamma globulins, which are main topic, including immunoglobulins. So what happens that there are two charge in lithium electrophoresis. The one end is negatively charged called cathode, and the other end is positively charged called anode. So as the serum proteins are negatively charged in inclined medium, they tend to move towards positively charged from negative charge. So as albumin being present in most concentration than globulins, they will be more negatively charged, and being smaller in size than other proteins, they tend to move more towards positively charged, and will show as larger peak as it can show in this paragraph. So if we can compare the normal protein electrophoresis with protein electrophoresis of the multiple myeloma, we can see a clearly sharp peak called sharp monoclonal M peak or M spike in the region of gamma globulins. So serum protein electrophoresis is a quantitative test that tells us about the concentration of the immunoglobulins present in our body or concentration of the proteins present in our body. So in this case, we can clearly say that there is increase in concentration of immunoglobulin that are present in our body. So in order to identify the type of monoclonal protein that is present in our body, we need another type of test called immunofixation. Immunofixation is a qualitative test that tells us about the type of monoclonal protein that are present in our body. In immunofixation, we use an antigen anti-immunoglobulin G, M, A, kappa and lambda. So upon reaction with their specific corresponding antibody, we detect monoclonal proteins on the basis of their absorbance. In immunofixation, we use another reagent called ELP. So these ELP binds with monoclonal protein that's present in our body. As we can see in electrograph, we can see a clear shadow of in the case of IgG, and case of lambda. These clear shadow shows the binding of the ELP with monoclonal proteins, while in case we see with IgA, M, and K, we can see a dark shadow as well. So it indicates that the ELP binds with the monoclonal proteins, and that's why there is a clear shadow in IgG and lambda region. It is an instrument called capillary Chughtai used for detection of the which used for the process like serum protein electrophoresis and immunofixation as well. Plain radiograph, X-ray. In X-ray, if we see these pictures in skull and humerus, we can see a clearly black spots, multiple black spots here and multiple black spots here, showing the demineralization of the bone due to increase in osteolysis of osteolysis process because of the increased osteoclastic and decreased osteoblastic activity. These black spots are called lentipunctured lesions. Bone marrow biopsy is a confirmatory test for the multiple myeloma, and there will be more than 10% of plasma cells with other, as I have described earlier, that other myeloma defining events like hypercalcemia, renal involvement as well. As you can see in this bone marrow aspirate, we can see a dozen of the plasma cells with eccentric nucleus, perinuclear halo, clock phase chromatin, and basophilic cytoplasm as well. In IHC, there will be CD138 positivity, which is a specific test for the plasma cells. Sorry, specific marker for the plasma cells. So coming towards our main topic, which is a development of anemia in multiple myeloma. First, I will discuss the pathophysiology behind the anemia. There are four basic mechanisms for the development of anemia in the multiple myeloma. The first one will be is the bone marrow infiltration, as there are clonal proliferation of the plasma cells in bone marrow. So what happens that these plasma cells crowding out the normal hematopoietic stem cells. So some of these hematopoietic stem cells also involved in the process of erythropoiesis, which is of course the production of the RBC. So due to the overcrowding of the clonal plasma cells, the process of erythropoiesis is affected, which will ultimately lead to the development of anemia. The other mechanism is chronic inflammation. In multiple myeloma, body constantly is in chronic inflammatory state. So body responds to that inflammation by secreting inflammatory cytokines and macrophages as well, like in case of anemia of chronic disease. So what happens that these macrophages bind at taken out almost all of the free iron present in our body, and as we all know that iron is required or necessary for the process of hemoglobin synthesis. So which ultimately affect the hemoglobin synthesis and can lead to development of anemia. Renal impairment, renal failure due to incorporation of the free light chain within renal tubules. There is specialized hormone called erythropoietin, which secretes from the specialized cells, renal tubular cells. So this hormone is required for the process of erythropoiesis. So what happens that due to the renal impairment, the synthesis of this hormone is also affected, which ultimately affect the process of erythropoiesis. Nutritional deficiencies, as multiple myeloma usually develop in the later decades of life, like in early 60s, mid 60s, or late 60s. So there could be another nutritional deficiencies as well. There could be a iron deficiency, B12, or folic acid deficiency. So these nutritional deficiency can also lead to development of anemia. Why multiple myeloma considered as a hidden cause of anemia? There are multiple reasons for that. The first one is due to their subtle and non-specific symptoms, including fatigue or weakness. Anemia due to multiple myeloma usually present early with the symptoms of fatigue and weakness. So we cannot actually link directly that symptoms with multiple myeloma. Baseline investigation, including CBC, will show us normochromic normocytic anemia. But as I have described earlier that in multiple myeloma there could be other nutritional deficiency as well, cause it occurs in older age and it is a cancer. So there could be another nutritional deficiency as well. So these indices can also vary. The other baseline investigation include which is important for the to diagnose multiple myeloma is renal function test. So serum creatinine level should be more than 2 milligram per deciliter. But in early stages of multiple myeloma, RFTs could come as normal. Slow and progressive onset, due to its slow and progressive onset in early stages of the multiple myeloma, there could be no systemic signs. Like there could be no systemic involvement there, like There will be not any bone involvement, renal involvement, or there will be not any hypercalcemia apart from anemia. Lack of immediate red flags, overlapping with other conditions. Again, multiple myeloma develops in later stages of life, so there could be another comorbidities as well. Like there could be a diabetes mellitus, hypertension, there could be any chronic inflammatory conditions that can cause the development of anemia, then that could be listed misleading as well. M protein not routinely checked. So, in order to establish the diagnosis of multiple myeloma, we need the detection of the monoclonal protein in our body, and for that we need protein electrophoresis or immunofixation or urinary protein electrophoresis. So these tests are not involved in the or M protein not involved in the baseline investigation. In summary, multiple myeloma is hidden, causes anemia is common, non-specific, and overlaps with many other benign conditions. Delaying recognition unless a clinician maintains a high index of recognition. When to suspect multiple myeloma in anemia? There are some red flags for the multiple myeloma. First one, there will be normochromic normocytic anemia. ESR will be raised with normal CRP. Unexplained renal failure. Total protein level will be raised, and the albumin globulin ratio should will be decreased. Bone pains, especially back. Hypercalcemia. Recurrent infections, and most commonly bacterial infections, cause of immunodeficiency, fatigue, and weight loss. So let's summarize the whole presentation through a case-based example. A 68 years old male presented with complaining of fatigue and mild backache for several months. His detailed history, including the increasing fatigue over 4 to 6 months, occasional dull lower back pain, especially at night, no history of blood loss or gastrointestinal symptoms, mild weight loss, which is 5 kg in 3 months, medical history is hypertension, which is well controlled. On physical examination, there is only a pale conjunctiva, otherwise no lymphadenopathy and hepatosplenomegaly. So we have an old patient with only complaining of backache, weakness, and fatigue, with no significant past medical or surgical history and no significant physical examination. So after baseline investigation, we found that there is hemoglobin is 9.2 to 9.2 gram per deciliter. Peripheral smear showed Roller's formation. Reticulocyte count was low. Serum creatinine level was raised, which is 2.1 milligram deciliter. Calcium level was also raised, which is 11.4 milligram per deciliter. ESR was raised. Albumin globulin ratio was low, and total protein level was increased. So after baseline investigation, we find that there is anemia and there is a renal involvement, as well there is abnormal protein counts. And there is also typical history of old patient with backache, weakness, and fatigue. So at this point, one should suspect that it could be a case of the multiple myeloma. So in order to further establish our diagnosis of multiple myeloma, we need another test uh, like serum protein electrophoresis to identify the concentration of the monoclonal proteins present in our body. Urinary, ये क्या हुआ? Sorry. Urinary protein electrophoresis to identify the light chain benzoate proteins. Uh, Immunofixation to identify the type of the monoclonal proteins that are present in our body. See a low dose CT scan, MRI, serum free light chains, normal kappa lambda ratio, and bone marrow biopsy, which is a confirmatory test. So key points is that fatigue from anemia was initial symptom, but workup reveals systemic clues. Hypercalcemia and renal dysfunction often subtle at first are classic findings. High ESR and oral formation are red flags for the plasma cell dyskaryosis. It is a flow chart explaining how should we evaluate the unexplained anemia. So we should suspect the multiple myeloma if there is high ESR, hypercalcemia, renal dysfunction, and bony pains as well. So in order to further establish, we need a specific test like serum protein electrophoresis, serum free light chain assay, immunofixation. So if they come as positive, we should perform bone marrow biopsy to confirm our diagnosis. And if they come as negative, we should evaluate for other causes of anemia. Take home message, always consider multiple myeloma in the differential diagnosis of unexplained anemia, especially in older adults with backache, as early detection can significantly impact prognosis and management. Thank you.